It extends from the nasopharynx to the anterior aspect of the middle ear space. It's a bony cartilaginous tube. The medial 2/3 is made out of cartilage, which you can see right here. Right here, this is the cartilaginous portion of the eustachian tube, and the lateral 1/3 is osseous or bony. The isthmus is the narrowest portion of the eustachian tube, which is at the bony cartilaginous junction, which has some implications for balloon eustachian tuboplasty. In the cartilaginous portion of the eustachian tube right here, the middle 8 to 12 millimeters has a component to it called the valve, the eustachian tube valve. And at rest, the mucosa and the eustachian tube valve is opposed, they're juxtaposed, and it's with dilation and swallow that the eustachian tube orifice opens and the mucosa separates. Here again, you can see the medial 2/3 of the eustachian tube, which is made out of cartilage. Again, it's collapsed at rest. It's not a complete ring. The cartilage is C-shaped. There is a posterior medial tube here. There's a medial and lateral lamina to the eustachian tube, and then there is a elastin hinge. So this part right here is made out of elastin, and that is how you have your cartilaginous portion of the eustachian tube. The anterior and lateral component of the eustachian tube is made out of fibrous tissue, and then we also have the Osman's fat pad here. The tensor veli palatini works on the lateral lamina, and the levator veli palatini works on the area of the posterior cushion. The bony eustachian tube has an intimate relationship with the petrous carotid artery, and that's very important because if you have a dehiscent carotid artery, excuse me, sorry. It's okay. I think we'll be able to move on here. Give me 1 second. So the implications here is if you have a dehiscent carotid artery, if you have a carotid artery aneurysm, you need to be careful when you do eustachian tube work. So just talking a little bit about function and physiology, the eustachian tube is collapsed at rest. The bony tube is always open. Looking at this image here, this is the posterior cushion of the eustachian tube. This is the slit, the opening of the eustachian tube at rest. And then this is the anterior cushion, or where the lateral lamina is. So when you swallow, the levator veli palatini pushes the posterior cushion medially towards the nasopharynx and posteriorly. So that's one component of the eustachian tube opening. And the tensor veli palatini acts on the lateral lamina. So you go from a slit or S-shaped opening to a round opening in a normal individual. It's not just the muscular function and the dynamics of the eustachian tube that allows for proper ventilation of the middle ear, but also mucociliary flow. Every mucosal surface in our head and neck area, the upper airway, has cilia that propel and project secretions to its destination. So a proper mucociliary flow is also important for a healthy middle ear and eustachian tube. Eustachian tube pathology arises either from anatomic variations, which we see in infants. You know, when infants, their eustachian tube isn't, it's not the same length, it's not the same orientation. In craniofacial disorders, anatomic challenges prevent the eustachian tube from appropriately functioning, or it could be functional or related to inflammatory factors. Chronic eustachian tube dysfunction, which we're all very familiar with, is also properly termed as functionally obstructive eustachian tube dilatory dysfunction. And that is really where balloon eustachian tuboplasty takes its effect. It's for that eustachian tube dilatory dysfunction. You can have a patulous eustachian tube, which is the exact opposite of eustachian tube dysfunction, where the eustachian tube is abnormally patent. You can have dynamic muscular failure. Again, you can see that in individuals with cleft palate, craniofacial disorders. What is eustachian tube dilatory dysfunction or chronic eustachian tube dysfunction? The prevalence of this is approximately 1% of the adult population, and it's associated with peritubal and intraluminal inflammation of the eustachian tube, which you can see in patients with chronic rhinosinusitis, URIs, an upper respiratory infection, patients with laryngopharyngeal reflux or patients who've been exposed to smoke. I have a picture of a tree here because when I have patients coming into my office with eustachian tube dysfunction symptoms and, middle ear effusion, when I go to examine their nasal cavity and their nasal pharynx, they're like, doctor, I'm here for my ear. And I explain to them, I say, the upper airway, going back to the unified airway model, is like a tree with multiple branches. When the main trunk of the airway is affected by allergies, inflammation, so will all the small branches. So you'll see in many individuals where, they have sinus disease, nasal disease, eustachian tube disease, middle ear disease. You can't really separate one from the other. And if you want to effectively treat the patient, you have to look at everything as a whole. Going back to the valve of the eustachian tube, again, the middle 8 to 12 millimeters of the cartilaginous tube is considered the valve. And it's that area, when you have a lot of inflammation, that valve doesn't effectively open and close. Signs and symptoms of eustachian tube dysfunction, I'm sure we're all very familiar with, so I'm not going to dwell on that. How do we examine the eustachian tube? We're kind of limited with what we have available for the eustachian tube, but otoscopic examination. You look for middle ear effusion, tympanic membrane retraction. You look for acicular chain erosion, cholesteatoma. Flexible and rigid endoscopy. How many people have used the rigid endoscope to examine the eustachian tube? The rigid endoscope, angled scope, 30 or 45 degrees. I personally use a 30-degree scope. And you really want to get a good look at the eustachian tube and its opening. This is a relatively healthy eustachian tube. There's no significant peritubal inflammation. You can see the slit-like opening in the eustachian tube. And so again, it's a healthy-looking eustachian tube. But here, these are a collection of images from some of my patients. Look at this eustachian tube. Look at this level of inflammation. You can't see a slit-like opening. You can see secretions blocking the opening of the eustachian tube. Very different picture from what we have here in the previous image. Here I don't know if you can tell the hypertrophic mucosa along the posterior cushion. Here, another eustachian tube affected by a lot of inflammation, hypertrophic mucosa, and a little bit of adenoid disease kind of pushing the area closed. This here, again, you really don't see an opening. There's so much inflammation and secretions. Same thing on this side. So really you need to investigate. You need to look at the nasopharynx. You need to look at the nasal cavity to get an idea of what's going on with patients. Here I have a video clip of a rigid endoscopy. So going back, this is this area here was a septum. This is the eustachian tube here. There's the hypertrophic mucosa. You can barely see the opening. I'm sorry, it's not the best of image. You can barely see the opening here. I'm asking the patient to elevate their palate by saying K. That's our wonderful nurse there in the background. And you don't really see, I'm asking them to swallow now. Again, you don't see an opening. So much inflammation, so much hypertrophic mucosa that it prevents appropriate ventilation through the eustachian tube. Again, the hypertrophic mucosa right there being pointed out to the staff. This is another image in the same patient on the contralateral side, and I just put this here. Let me go back here. I put this here because I want you to see, look at the secretions, the nasal cavity secretions. Look at it kind of right where the eustachian tube opening is. That stuff impacts that level. It irritates, it causes inflammation, let alone the retrograde flow into the middle ear space. So how do you treat eustachian tube dilatory dysfunction? Medical management, you know, nasal steroids, nasal antihistamines, oral medication, whatever you can do to kind of settle down the etiology. And if it doesn't work, again, for ages, really all we had available was to just do a myringotomy and place a tube. And it's a very exciting era for us otolaryngologists, as otitis media is one of the main diagnoses that we encounter in children and adults. And you know, there's a promise with balloon eustachian tuboplasty, so we'll talk about that a little bit. There's also stuff called, you know, microdermabrator or laser-assisted eustachian tuboplasty, where you take some of that hypertrophic mucosa that I demonstrated to you off with the laser or microdermabrator. I usually personally don't do the laser, but I do use a microdermabrator, and I have some good results with that. Balloon eustachian tuboplasty, the first time that we had published data in the literature was in 2010 by Ackerman. It is a minimally invasive approach, and there's growing clinical interest and evidence globally on this procedure. There are various indications for this: chronic otitis media or persistent otitis media, symptomatic eustachian tube dilatory dysfunction. If you have a type B or C tympanogram, non-adherent TM atelectasis. If you have adherent TM atelectasis, at this point in time, we don't recommend doing eustachian tuboplasty. Flight and scuba diving, barrow challenge, and in individuals where tympanostomy tubes have shown to work in the past. You need to be careful. You don't want to make the mistake of accidentally diagnosing someone with a patchless eustachian tube or superior semicircular canal dehiscence or even TMJ dysfunction with eustachian tube dilation and dilate them. The last thing you want is to have a patient with a patchless tube and dilate their eustachian tube to make them even more symptomatic. Contraindications for balloon eustachian tuboplasty are really few, and the most important one is if you have a carotid artery bony dehiscence, or if you have an aneurysm affecting the petrous carotid area, you do not want to do a balloon eustachian tuboplasty. Technically, the balloon isn't supposed to get into the bony tube, but still, as of now, that's a contraindication for this procedure. In the interest of time, I'm just going to briefly go over this. Right now, it's suggested to do a CT temporal bone before each intervention, just to look for a dehiscent carotid artery. Tisch in 2013 said we reviewed 1,000 CTs, we reviewed 2,000 eustachian tubes. We didn't find any carotid artery aneurysms or Barencies. But then we have Abdulaziz in 2014 who reports 18 aneurysms or bony dehiscence out of 284 CTs reviewed. A recent systemic review of 9 studies was performed, published in 2015, and 8 of the 9 studies did do CT temporal bones before the procedure. I'm going to be honest with you, I don't do a CT on every patient beforehand, but that is what is suggested as of now. So here we have a couple of clips. Oh, where did he go? Can I ask you to be present here, please? Yeah. Oh, came back. So here, I don't know if you can see this upper image here. Now this is a poor view of the eustachian tube, but what I wanted to point out in this image is that the eustachian tube opening can be identified posterior and inferior to the most posterior aspect of the inferior turbinate. So the inferior turbinate, the posterior aspect, is a good landmark for identifying the eustachian tube. You know, some of the eustachian tubes are very easy to identify, but if someone has a lot of inflammation, a lot of hypertrophic mucosa, it might not be as simple. Here we have a eustachian tube post-dilation. I'm removing the catheter, and here you see a balloon catheter in place, dilating a eustachian tube with surrounding secretions and inflammation. I'm just going to show you this clip here. You see the, one other thing I wanted to demonstrate is with the catheter, you can actually push the posterior cushion aside a little bit, and if you can angle your scope in, you can get a good glimpse of what's going on inside the eustachian tube. Let's see if we can give you guys a better, but just kind of, you know, it gives you a good idea. Right there, there's secretions, but sometimes you can see scar bands in people who've been chronically inflamed. So if you do the balloon eustachian tuboplasty, you may want to use that technique to take a brief glimpse inside the eustachian tube. I have another image here of just demonstrating this is the inferior turbinate here. This is the right side. Going back. Great pause there. Okay, going back. That's the inferior turbinate and then the eustachian tube. So I'm demonstrating the inferior turbinate, the posterior aspect. The tube goes in and just inflation. It's important, if you hit resistance, you don't want to advance. Usually resistance means that you're at the isthmus, the bony cartilaginous junction. You do not want to advance. The other thing is you don't want to cause a mucosal tear in a false tract. So if it doesn't go easily, something's wrong, come out and reorient yourselves. That's that. And then here just the eustachian tube, the balloon is being deflated and removed. And advance it in a little bit to take a good look at the dilated eustachian tube. Okay. Complications with this procedure. You can have epistaxis, false tract formation, which you really want to try to avoid if you can, soft tissue emphysema when you do have a false tract formation. The tympanic membrane has been reported to rupture in several of these cases. I haven't had it happen, but it is reported. You can have tinnitus, a patulous eustachian tube, which I do know of one case, and I'll show you the images. Cardiac dysrhythmias and systolic hypertension can occur as well. So if you have any cardiac abnormalities, just abort the procedure. If the anesthesiologist is giving you a warning, you may be compressing the carotid plexus and just come out. And hypothetical risks are worsening eustachian tube function or carotid artery injury. To my knowledge, there have been no reports of carotid injury as of now. Postoperative management, you want to continue to treat the reasons for inflammation. We ask patients to not blow their nose for a week. We initiate Valsalva maneuvers the next day, and obviously there's a pre-op audio and tympanogram. We do a post-op audio and tymp as well. Now, how does this work? Why does it work? And we're just trying to understand. Really, this procedure is at its infancy, but Poe's group in 2015, they published something where they took a biopsy of the mucosa pre and post dilation, and they found that a lot of the inflammatory markers were no longer there, and there was reduction of inflammatory epithelial changes and submucosal inflammatory infiltrate. So basically, that thick inflammation and hypertrophic mucosa is kind of being replaced with thin scar. Again, this is evolving. We're going to learn more as our researchers work on this. I chose 3 of the larger studies that have been published to share with you. Tisch in 2013 talked about their results with 320 eustachian tubes, and they found symptomatic improvement in 70% of patients. Silvola in 2014 reported 80% success rate, defined as the ability to perform a Valsalva maneuver post-op in 41 eustachian tubes in 37 patients. And the largest study out there right now is from Schroeder's group in 2015, where they had 622 patients, 1,076 eustachian tubes, and overall improvement in eustachian tube scores greater than 70%, and eustachian tube score improvement at 5 years was actually 82%. And obviously, at 5 years, some of that's also passage of time and kind of natural resolution of disease. I'm going to talk about microdebrider eustachian tuboplasty a little bit. Anyone here do that? Anyone use a microdebrider to? So there's limited literature on this technique, but I've had great results with it, and I've been very, very surprised looking at pre- and post-op images or videos. So it involves removal of 1 centimeter of the hypertrophic mucosa that I've shown you, all the way down to the level of cartilage. Again, it's easier said than done. You look on YouTube and you have these pristine, perfect images, but it's easier said than done, getting the microdebrider and the endoscope in a narrow nasal passageway that's inflamed to begin with. But, you know, the results are really great, and I'll show you some post-op images. And what happens is that hypertrophic mucosa gets replaced by thin scar. You want to be careful. You don't want to nick the anterior cushion in other areas, because obviously if you have 2 raw surfaces, you're going to get mucosal bands and scarring, which may worsen the function of the eustachian tube. Here I just talk about the surgical technique, which I won't go into for the interest of time. But this here is a eustachian tube hypertrophic mucosa. You see that? Very, very, very inflamed. This is post-dilation. And post-dilation with the suction kind of removing that hypertrophic mucosa. So what I did in this case is I took down 1 centimeter right here, and then I put the balloon in afterwards as well and dilated a little bit after the microdebrider eustachian tuboplasty. I don't have post-op images to show you. I just recently did this, but I can tell you a week post-op, I saw some good results. So I'm excited to see what's going to happen overall. Again, the literature on this is very minimal. Metzin's group, Metzin and Poe in 2007, reported their preliminary reports on 20 patients, and patients did have concurrent sinus surgery, and oral fullness improved in 70% of patients, and post-op tympanogram improved in 65%. Again, if I ever have a big volume, which I think I will in a couple years, I'll try to add to that data. Here, I'm showing you someone who underwent a eustachian tuboplasty, microdebrider assisted, no balloon. And you remember those images I showed you with the hypertrophic mucosa? This was the same thing. But here you can see how the posterior cushion has healed, the difference, and then you can actually see an opening now. And when the patient swallows, something does open. So this is like a month post-operatively. pre-op images looked like what I showed you before. So there also is a description of laser eustachian tuboplasty, where a laser is used to remove the mucosa and cartilage along the posterior cushion. We only have a few articles in the literature talking about that. In the interest of time, I'm just going to move on to patchless eustachian tube and just show you a couple of images and I'll be done. So a patchless eustachian tube is the opposite of the chronic eustachian tube dysfunction, where the tube is abnormally patent. Patients can have autophony, oral fullness, roaring tinnitus. On physical exam, you can see a triangular opening at the eustachian tube orifice on nasal endoscopy, which doesn't close, and I'll show you an image in just a second. You can see a flaccid tympanic membrane that moves in sync with nasal respirations on otoscopy as well. Pregnancy, excessive weight loss, or even a couple pounds of weight loss can exacerbate these symptoms. This is unfortunately a patient who had undergone a eustachian tube balloon dilation, and look at that eustachian tube now. You see how it's just kind of too open? And you don't want that to happen. We really have to select our patients appropriately. And so afterwards, like a month later, she came in complaining of autophony and fullness in the ear. And you can see the other eustachian tube. You see that? The hypertrophic mucosa? This is post-dilation. Now I don't have the entirety of the eustachian tube to show you. So, this eustachian tube, I can't show you the orifice. Patient benefited, but the other one, she has a patchless tube. So how do you manage it? Watchful waiting. There are, patients can gain some more weight. There are some head maneuvers you can do. There is some topical nasal therapy or surgical. And I'm going to be honest, I don't think there's a really good surgical option available for patchless eustachian tube. You can inject with fat, you can inject with gel foam. I have done cartilage implantation along the anterior cushion to kind of pulp it up a little bit to prevent symptoms with good results. You can plug the eustachian tube with fat. You can cause scarring. There are many, many things and options available, but really, if there was one good option, we wouldn't have all these different reports, and so I don't think we have a good solution yet for that. So in summary, balloon eustachian tuboplasty is at its infancy. It's receiving a lot of attention around the world. It's a safe procedure. And if and when its efficacy is proven through randomized controlled trials, which we don't have yet, it will serve as a revolution in management of eustachian tube dysfunction. And with that, I appreciate your time and attention.
Any questions?
Yes.
Oh, I can. Essentially, you're trying to attain controlled scarring. So one trouble is that I do a lot of sinus work. You never want circumferential scarring.
Exactly.
You see if they'll make a balloon for you that only inflates on like semi-lunar. You're going to get a lot more consistent results if you only cause fibrosis on half of your
Eustachian tube. It usually doesn't, there's no mucosal lacerations or, tears, usually. Yeah, and so, again, no one's really reported worsening eustachian tube function, but it's a fruit for thought. We haven't encountered it yet, but we've had patients with vesicular chain reconstruction over and over again, which has failed, and we've complemented it with a eustachian tuboplasty, and suddenly it's worked in patients who've had multiple revision surgeries in the past. Tympanoplasties that failed, the subtotal or neototal perforation, eustachian tube dilation, and the tympanoplasty has succeeded. I think Dr. Dennis Poe at Harvard is actually working on gaining data on that, and we've had some good results, so I think it's exciting, very exciting. Yes, Doctor.
Like trauma.
Correct.
Aren't you operating from any fibrosis in this area, synechiae? Especially you have used the microdebrider.
The microdebrider, yes. So the microdebrider is different. Just take out all the way down to the level of the cartilage, and then you have thin scar. I showed you. I have a couple of post-op images to show you. Just on the posterior cushion, a centimeter. I don't do the laser eustachian tuboplasty where you go into the lumen. Just on that posterior cushion, as if you had adenoids growing onto the eustachian tube. In children sometimes that happens, and you may want to take it down. So as long as you just stick to that 1 centimeter window, I believe you should be okay, but I'm sure there are risks of further abnormalities.